All right. Okay, so we're going to talk about weed and glaucoma. So I gave this talk originally about 2 years ago, so I've updated all the slides for you to reflect current state legislature, where we're legalized, where we're not legalized, and ultimately we're just going to talk about how a glaucoma doctor, how any ophthalmologist deals with ophthalmology, eye pressures, glaucoma, and the weed. All right, so financial disclosures are for Alcon Pharmaceutical and Surgical. They are not relevant to this talk. Okay, so weed has been obviously utilized within the United States since the early 1960s, and it was actually in 2012 that there was a big political campaign to legalize marijuana in the United States. And one of the ways they tried to get the state legislature to approve it was they promised that some of the tax from marijuana sales would go to support local schools. And that's where you see this big climb, is 2012 and then up. Just so everyone's aware, so there's two taxes usually on weed. One is a 15% sales tax, the other one is an additional 15% sales tax on the Esquire tax. So it's 30% taxes on weed, and Denver actually has an additional 5.5% tax locally on marijuana. So states across the United States have been increasing their legalization, one, because the taxes that are collected from marijuana are substantial and supportive for their state community. And then this slide is updated. This is as of 2023. So the original states to legalize were Colorado and Washington. This is in 2012. And then in 2021, when I originally gave this talk, there were 37 of 50 states that now allowed whether it was recreational or medical use. And now, since then, in the last 2 years, only one additional state, so it's now 38 out of 50, have legalized their use for weed, whether it's medical or recreational, in the United States. The important thing to know is that federally, it is still illegal, largely because it's considered a Schedule I substance. So I'm going to walk you through kind of scheduling, just as a reminder. So your Schedule I compounds, these are, think heroin, think LSD. Schedule IIs are going to be more like your opiates, your Valiums. Schedule III is usually like Tylenol number 3. So you can't do any research on a substance that is considered a Scheduled I, like marijuana. So there's no way to really know what marijuana could do for several medical conditions, whether it's anxiety, musculoskeletal, glaucoma, because you can't, it's hard to get it out of a Schedule I classification. The bureaucratic process that is in place to try to get it out of Schedule I is so complicated, they make it near impossible for it to actually happen. So that's what this box up here kind of walks you through. So if you petition the DEA to remove marijuana as a Schedule I substance, it actually goes to Health and Human Services, and they have a whole bureaucratic process. It'll get lost in there and it won't go anywhere. The alternative to this process is you would need an executive order, which we were hoping would happen actually with the Biden administration, which didn't happen, or you need other than an executive order, which again is unlikely to happen probably with the current administration. There's also no safe banking. So for example, if you wanted to own a weed farm in the state of Colorado, you need a license. You need a license to grow or you need a license to dispense. There are no licenses currently that are being produced. You would actually have to buy one from someone that already owns a grow or a dispensary, and you can't go to the bank and get a loan. That's where the safe banking comes in. You have to have the cash or have friends with the cash to be able to get one of these. So again, it's unlikely we're going to be doing a lot of additional research on marijuana until we can get it out of Schedule I. And I always, when I see this slide, when I was prepping, it occurred to me, I was like, marijuana doesn't often kill a lot of people. Alcohol does. Drunk driving does. But yet, alcohol is not Schedule I. So let's talk about weed and the components within weed. So there's about 400 different cannabinoids within a marijuana sort of particle. There's 2 that are the active ingredients. That's your THC and your cannabidiols. So THC, think your psycho-anaphylactic type stuff. Think mental health. Your cannabinoids, that's where you get into more of this sort of musculoskeletal, neurologic type components, epilepsy, MS. And then the delivery systems. So you can inhale it, you can oral, so edibles or sublinguals, and then there's lots of topical or transdermal patches and creams and ointments that a lot of the dispensaries will sell. And when you buy from a dispensary, you'll get a printout from one of these labs, depending on where you're buying, that kind of walks you through what's in it, the breakdowns. And just like a lot of supplements, this is not FDA regulated, so you may get varying amounts of THC or cannabinoids depending on what you're buying and where you're buying it from on Tuesday versus Thursday. So it's a little hard to tell exactly what you're always going to be getting. And terpenes, think of these as like different types of flavors of weed. All right, current climate with marijuana. So there's certainly increased access, which we showed you in the first few slides, wider public acceptance, and a diverse set of patients who are interested. So, I mean, I have 60 or 70-year-old patients coming in and asking me about the use of weed and their glaucoma. I've got 20-year-olds asking me about it, so it's not really age-dependent. And we're often looking at it when our current allopathic therapy doesn't always work, or you have a pressure of 9, you confirmed on an eye care home, it's consistently running at 9, and yet their glaucoma is getting worse, which we know is probably the nature of the disease, but people are always looking for an alternative to help them save their vision. So how does a glaucoma specialist handle it? Well, kind of usually always go back to the data as much as I can with patients. So what data is out there is very anecdotal. Sample size in the studies is like maybe 9 to 12 people, but I will show you what I have. And if you're going to remember anything maybe about efficacy of pressure-lowering effect with weed, that's the line. So it typically lowers pressure about 25%, but it only lasts for 3 to 4 hours. So you'd have to be high continuously. And I did the numbers on this. So this is like 8 to 12 joints a day, and you're looking at about $8,000 a year. So it is still more cost-effective for people to actually use truly proven allopathic therapy and stuff that has evidence, good evidence data behind it. And this effect only was effective for 60 to 65% of users. There's one prospective study that kind of helped confirm, which we already thought, that the inhaled form is the form that really lowers eye pressure. Edibles, subdermals don't really do anything. It's inhaled form. The one study tried to look at topical eye drops, and that's probably the study that showed that it likely has an impact on the trabecular meshwork, which is where this slide comes in. So, and if any of you have ever looked at Ropressa or Rocklatan data, this is exactly where this slide deck came from. I'm a former speaker for ARI, which is now owned by Alcon. But this is the site of action that we think THC, specifically, THC impacts outflow. How exactly, we don't know, but this is the idea. So that's why I pulled up this slide, because I thought, well, this is relatively helpful. So THC is supposed to increase outflow, potentially decrease episcleral venous pressure, increased hyperemia, the same kind of stuff you see with Ropressa and Rocklatan. So downsides. So the biggest systemic downsides, there's a lot on this list, I will highlight the ones, is lower blood pressure. Which again, if you're a normal tension glaucoma patient, we're not looking for low blood pressure. We're hoping hopefully to increase your blood pressure, particularly at nighttime. Elevated heart rate was the other big one. These two come up mostly in the literature, and again, it's relatively sparse literature. And then the ocular side effects are the things everybody knows about: red eyes, irritation, decreased lacrimation, ptosis. These are all noted. Most of you guys probably know these. This is a study that was actually done here with Leo Siebold at UC Health. So they actually interviewed over 200 dispensaries and asked them some very specific questions just to get a feeling about their understanding of how, if people are coming in to buy from their dispensaries, what do you tell them if they're asking about what they can buy for glaucoma? So if you were to ask them, hold on, because I can't read it. Is there a way to take it that's best for glaucoma? Most dispensaries said it was topical concentrates over smoking. What type of marijuana do you recommend? Most of them said CBD over THC. Should be the opposite way around. Dosing recommendation. Most of the dispensaries just said multiple times a day. And is it safe? About 74% yes. They thought it was safe to take for glaucoma. Most of them did understand that the evidence is anecdotal. And about 36% recommended discussing use with a physician when they asked if it was a good idea to recommend asking a physician first. When I wrote this original article, I actually went up to a dispensary and I walked in. I'm a novice. I was like, I know nothing about weed. Tell me what you would sell me. And what they really focused on actually was musculoskeletal type issues. They talked a lot about fibromyalgia or MS. And we're really pushing lots of bath salts that day. I'm not sure why. So when I asked, I said, well, I hear it's good for glaucoma and it lowers eye pressure. One person out of the 6 that were working that day were like, oh yeah, we heard that too. Nobody else really knew anything about it. So I think it's probably still low likelihood if you walk into a dispensary, they're gonna try and push weed for glaucoma, but clearly something we should probably still know about. All right, AGS survey. So the American Glaucoma Society said that 38% of respondents reported at least one patient was asking them about weed and glaucoma a week. 37% of responders have patients that will use it for glaucoma. Personally, in my practice, we do ask about recreational drug use when you come in as part of your screening and your history. More and more, I think people are willing to say, yes, I use marijuana edibles. It's usually edibles, seems to be, recreationally. And we certainly ask about it if we're taking patients to the operating room because their THC use can impact the amount of anesthesia that they need for their sedation. So honestly, the anesthesia component seems to be more prevalent within practice. But if you've got patients who consistently run at 9 and they're getting worse, maybe always a good idea to ask about recreational use again, just in case I missed it the first time through. And 55% of respondents report that patients have requested a prescription, a medical dispense prescription for weed. We don't have those. I don't give those out. I don't recommend giving them out. And if you need a statement from the AGS, this is the current position statement. It is on the website. Although marijuana can lower the intraocular pressure, its side effects and short duration of action, coupled with a lack of evidence that its use alters the course of glaucoma, preclude recommending this drug in any form for the treatment of glaucoma at the present time. And then nope, we'll go for this one. So what do we do? Well, I think you just have to make sure you're educated and that you can evolve your practice so that you can have what you feel an educated discussion with your patients. Talk to them about it. Don't be afraid to talk to them about it. Most of us, I think, probably hopefully have a good, trustful relationship with our patients so they feel comfortable telling us about things like this. You can give them literature. I'll show you a slide in just a second that actually has a document that you can print off the AGS website that you can keep in your office and you can hand out if you would like. Staying in the know. And do I interfere with a patient's use of marijuana? Again, I usually just try to talk to them about the adverse events. We'll talk about blood pressure and heart rate. Men, you can get them with the testosterone, usually. Or the gynecomastia usually also does the trick. But it's not maybe my place sometimes to tell people what they want to do recreationally. It's like, you need to stop drinking. Well, I mean, all things in moderation, maybe, in a safe place. And this is actually a card when I went and toured the dispensary that was sitting on the desk when I walked in. I was like, oh, I'm going to steal one of these for this talk. Communicating with patients, again, this is directly from the AGS. I've given this to some referring optometrists before if they were just looking for a reminder on a nice statement that they could give to patients if they don't want to have to get into details. Again, there's no good scientific evidence that cannabis is better than current allopathic therapy. And this is the handout. So this was actually written by Mona Kaleem. She's at Wilmer. And it's still good today. If you don't recognize this slide, this is the same. This is actually the one from 2021. The one I showed you is the one from 2023, which is about when this was done. But you can print this out directly from the website. You go under handouts. It's right there. So I keep these in the office as well if anybody asks. References. There's the family. And the loyal, trusty dog who loves to sit with me while I edit videos in my office. This is Toby. My cell phone and my email are here, so if anyone has any questions, please don't ever hesitate to reach out. We're happy to answer them. And if there's any questions, I'm happy to take those.
I didn't hear any mention about marijuana decreasing the threshold for psychoses as a potential negative.
I am probably going to be less versed on the psychosis component of marijuana. I try to kind of keep this talk mostly to pressure-lowering impacts, but yeah, the mental health component is certainly probably the main reason that people use marijuana.
Marijuana syndrome, which we see escalating in our young people, which is what you're talking about, where they have that constant vomiting, and they will not stop. They don't see any relationship to what they're using, but it's real common.
So I've had patients to talk to me or ask me about medical marijuana, and I give them similar information. No one has said that they would like to try it. Do you have patients that have tried THC, and then do you monitor for them in a certain way?
No,
Any
I really
experience
haven't.
with clinical treatment with it?
I haven't. I really haven't had anybody say, Doc, I'm only going to try this. Again, usually if it comes up, it's kind of like a supplemental therapy or something adjunct to allopathic therapy. I can tell you when I trained in New York, which I know Dr. Kruger mentioned, we had many patients who were very big on supplements, and there were several in their minds where THC was considered an additional supplement that they were going to use with their therapy. My attending at the time was very senior. He had a lot of clout, and he pretty much just laid it out and was like, no, you're not going to use this. He was also cash only. So again, if someone wants to use THC alone, as a provider, I would probably just say I strongly do not recommend that. If you want to stay with me, if you want me to help take care of your glaucoma, I'm going to strongly encourage you to, whatever it is, medications or lasers or surgical therapy. At least let's try the proven techniques. And if you want to still consider THC, then we'll figure out a safer way to do that. But again, it only lasts for 3 to 4 hours. So, well, I took a joint before I came in, Doc. Well, sure, your pressure's 8. That's great. And it does. It will get you pressures in the single digits. But it just doesn't last. I really would encourage folks not to use it. And in fact, there is a study that showed that the younger the patients who were trying this, and when they did look at pressure fluctuations, actually advanced to quicker or more severe glaucoma faster, and likely related just to the pressure fluctuations that they're experiencing, because it only lasts for 3 to 4 hours, and the swings are more likely to cause retinal nerve fiber layer loss and then visual field deficits than if you maintain a steady pressure.
So I think what you're speaking of is not in our older population with glaucoma, but definitely in the younger population. I think there's evidence that marijuana use can induce an earlier evidence of bipolar disorder. So it can bring out more mental disorders. I don't know if that's true in an older population or not. But the second thing I was going to ask is, do you know anything about the financial side of this? Because it seems like a lot of these dispensaries, as you said, getting a license is very difficult. You have to buy them.
Yeah.
So they're making a lot of money because it's a Schedule I drug. So it's regulated to the point that it's almost like a drug running kind of thing. I mean, in my opinion, I think they make a lot of money off of that. I mean, what are your thoughts?
The profitability of the various farms, I think, ranges. I certainly know folks who have had grows or dispensaries and they've gone under and they've sold their licenses. There are plenty that make lots of money. And actually, the one that I toured, they were all talking about it, sort of whispering, I should say, because I guess some senator from Mississippi was coming up to tour their dispensary because they're looking to legalize in Mississippi, and often it's just because they want the tax revenue. The states want, and again, like you can't use a credit card when you buy this stuff. It's cash or a debit card. I mean, the armored trucks will roll into the parking lot, they haul out the cash, and then it goes off to a bank somewhere. But it's like at minimum 25% tax when you purchase this stuff. And it's not cheap, you're right. what I saw when I was in there is nobody probably spent under $100, depending on what they were buying, whether it's resins or buds, or no one really buys the joints. They usually buy the buds and then they roll it home, I think. But
So I have a question.
Yeah.
So I was involved in a textbook called Cannabis in Medicine. It was published in 2020. And I did the chapter on ophthalmology. And at the time, only evidence we could go with was mice. Or outside of the U.S., there were some studies. But here in the U.S., to your point, there really weren't any.
there's nothing.
And one of the things that caught my attention, and I just was interested if you're aware if it's changed or not, was the fact that the THC, if you can get it pure form and by itself, not commingled with hemp, not commingled with CBD, it really does, to your point, lower the pressure. But the problem here in the States is people grow it, they, in their own backyard, or they buy it at a dispensary, and it's not pure, right?
Correct.
And then the CBD, cannabidiol, that's different in that, at least in the mice, get increased pressure.
It will increase, correct.
And hemp is another thing we haven't even talked about, because you can get that in the grocery store in your food. And what does that do to pressure?
They'll sell it at Sprouts in some kind of a lotion. Yeah.
Right. And so all I'm trying to say is, and again, if you're going to use CBD because you think that's going to help your glaucoma, they don't even know that it actually, at least in mice, increases eye pressure. It doesn't lower it. And to your point, you have to stay high every 3 hours, and that keeps you from your job.
Your job.
And it should keep you from driving. Of course it doesn't, but I mean,
It doesn't.
right?
Yeah.
Anyway,
No.
I don't know if you have anything to add to that.
Hemp, I don't. I didn't get into that as much. But yeah, you're correct on the cannabinoid. I read the same. And again, it's hard to know what percentage you're getting every time you purchase. You get your printout from a lab, but the accuracy is maybe questionable too. Again, a little bit like supplements, because it's just not regulated. Oh, go ahead.
Sorry, really brief question. You elaborated just briefly on, I think there was an observational study that said that smoking alone would decrease the pressure, but other forms would. Did they ever
Typically.
elaborate why that may be the case?
No, I have nothing additional to add to that, because I thought that was interesting too. It's primarily the inhaled form. Now, again, with the eye drop study, I can elaborate on that a little bit. It was more getting through the cornea. So it was, hydrophilic versus hydrophobic components. How do you keep the active ingredient alive when it gets through the aqueous humor and then hits the trabecular meshwork? They speculate a lot about that. And again, it would be really interesting to study, but I can't study it. And the drop, they are very
burn.
irritating and intense redness. I mean, I know a lot of us know about Ropressa Rocklatan redness. This is very, very similar. So I wish I had more for you on inhaled versus edible and oral, or the brownie versus other. But I don't. And that's what that additional 15% tax. So there's 15 on the sales. The other 15 is when they take it from, whether it's from the grow to the dispensary, or from a production facility where they're making the vape pens or the brownies. That's where the additional tax comes in, and then Denver tacked on an additional 5.5. So very profitable for the state.
Stephanie, it sounds like in New York City, most of the weed is sold through like illegal shops and
Oh,
not
yeah.
through the regulated ones.
Walk
Is
through
that-
the East
Is that common
Village.
in Colorado too?
Just taking the second hand. That was my experience when I was there too. Yeah, and really, I've gotten probably relatively equivalent questions about weed, when I was practicing in New York and then practicing here. It's been like roughly the same kind of percentage of folks that ask me about it. But yeah, in New York, they have dispensaries. I don't remember them being as prevalent as they are when I feel like I drive around the Denver Metroplex. But you could usually just get them on the curb.
Yeah, I think their tax revenue projections are much lower than.
A little different, yeah.
The reality is less than the projections because
New
of the
York gets
illegal-
you in tax in every other way. There's one behind you.
Excellent talk. Thank you so
thank
much for this important topic. As a glaucoma doctor, we face this almost weekly, as the studies have shown. I'm familiar with the mice study, thanks to Jane, in terms of CBD having a detrimental effect on IOP. And I've seen it clinically, and I kind of compare it much akin to steroid response in some of my patients. So I now routinely ask about CBD use in those patients. Is there any studies that you're aware of that are being done on humans looking at the CBD and the IOP response?
None that I'm aware of.
Thanks so much, especially like for our generation. This is something that's coming up a lot and important to talk about. One thing I wanted to put on y'all's radar, also from our generation, and just to ask your experience with this, vaping is huge now, especially for THC. And in terms of contaminants and dosing, like it's totally different from smoking. So I wanted to know what your experience, I guess, was with that.
I probably know about as much from vaping versus smoking actually as you do, to be honest. I mean, it's still tar and carcinogenics and toxins, whether it's THC or it's tobacco. But really, the nuances between the two, I am not that familiar. But yeah, you're right. We see a lot of people vaping. I see tons of my own office staff vaping. I try to turn a blind eye.